Okay, so our first topic for discussion today is the realities of TFR in resource-constrained Latin America. And it's really a great pleasure to introduce Dr. Katia Pagnano from Sao Paulo State in Brazil. So Dr. Katia is a very well-known hematologist from the Center for Hematology and Hemotherapy at the University of Campinas in Brazil. Katia, thank you so much for joining us today. Our other expert for this first session is Professor Ehab Atallah from Milwaukee in the USA, who is a giant in the field. He is Professor of Medicine and Section Head of Hematologic Malignancies within the Division of Hematology and Oncology at the Medical College of Wisconsin, USA. Welcome, Ehab. It's a privilege to have you here. But I should also say that Ehab and Katia are not only great physicians, they are intrepid adventurers too. They both summited Mount Kilimanjaro in Tanzania in 2019, raising funds for CML research and physician support through the International CML Foundation Climb for a Cure initiative. And believe it or not, they have both put their hands up to climb for a cure for CML again this year, heading to the Annapurna mountain range in the Nepalese Himalaya. So I'll send a link around to everyone in my follow-up, and I hope you'll have a look. And you never know, maybe some of you will join them on their next climb for a cure, wherever that might be, perhaps somewhere in Latin America, who knows? Okay, so Katia, would you like to share your slides with us, please?
Okay.
And as you're getting your slides up, I'll share with the audience how we'll run this session. So Katia will spend a few minutes identifying the key issues, problems, and challenges that she and other physicians in Latin America face in pursuing TFR pathways. Katia will then present a case, Ehab will comment on it, and then we'll open to the audience for 1 or 2 questions and comments. Katia will present a second case, Ehab will comment, and then we can open up for a longer session of questions and discussing any issues relating to TFR that you like. Okay, thank you. Oh, and just finally, I'll introduce the speakers for the next topic when we get to it, but just so you know, we have Karolina Pawlowski and Professor Jerry Radic in the audience already, both very experienced in TFR, and so we'd welcome any contribution they want to make to the discussions too. Okay, thank you, Katia.
Okay, thank you very much for the kind introduction, Arlene. I'm very happy to be here with you tonight, and I'd like to thank the ICMLF for the invitation. It's a pleasure to share the stage here is Carolina and Ehab and Dr. Jerry. So first, I'm going to talk about the reality of TFR in Latin America. We know that our region is a vast region. We have many economical difference between the countries and also between the healthcare barriers. So we have one of the main problems that impairs TFR in Latin America is the PCR monitoring that we need to do the discontinuation. In most of the countries is not still reimbursed. Some places it's reimbursed for the regular monitoring, but when you need to increase this monitoring, you cannot afford for the cost of the PCR. So most of the patients in Latin America that discontinue treatment are those patients that are included in clinical trials. So this is something that we need to change. So maybe Carolina can talk a little about this later when the PCR session, but I think it's one of the most major problem is the access to the tests to monitoring of TFR. So just to do a brief review what we are doing in Latin America. In Brazil, the first discontinuation trial was the study NSTOP. It was conducted in 7 centers in Brazil. So some patients were included in this trial. And then we came the university trials. One of them is conducted at my university of Campinas. This trial included 32 patients. At the same time, at the University of São Paulo, there was also a discontinuation trial that included 31. And we now are running a second discontinuation trial that is supposed to be multicentric. We have 2 institutions participating. We have 41 patients, but we are waiting for the approval of the ethical committee for the inclusion of more centers. And we have also a private practice institution clinical trial that included 20 patients, and I'm going to talk about this later. So just to show you that in our trial, we included 31 patients. The criteria for the inclusion was MR 4.5 in 2 years, for 2 years. And we have a very successful TFR rate of 6%. This was at 30 months, but now the same population that has been followed has now 5 years. We have only one death by COVID-19, unfortunately, but we didn't have any other relapses so far in this trial. The second trial, it was conducted at the University of São Paulo. So the molecular relapse-free survival was very similar to our trial. The criteria in this trial was to stop treatment was to be in MR4 or MR 4.5. And in this trial, they noticed that the successful rate was higher in the group that stopped the treatment in MR 4.5. Only 31% of this patient relapsed. So it was a better result. And we have experiences from Colombia. This is data from the Colombian registry. In 449 patients, they had 29 patients eligible for TFR and 27 discontinued treatment. And the TFR is around 60% too. And they did the estimated savings for the Colombian healthcare system for these patients was $1 million. And the cost of the PCR analysis performed for these patients to do the TFR was $35,000. So it's a huge economic factor during the discontinuation. Argentina, Carolina conducted this trial. It's called the ASTI trial. And they included 50 patients. The TFR rate in 24 months was 65%. I'm not going to go into detail in all this table, but I'd like to pay attention. The total savings of this trial so far, it was $2,900,000. And the total saving per patient, according to median age and life expectancy, was $714,000. So it's a huge economic impact for our countries. Also in Brazil, we have this study of a private institution that included 20 patients, and they also calculated the costs during the discontinuation. 12 patients, 60% sustained TFR, the median follow-up of 14 months. And the cost of the treatment without discontinuation would be $779,000 for branded imatinib, or $2 million, almost $3 million for imatinib copies. And the saving during this period of follow-up was $719 for branded imatinib and $429 million for imatinib copies. So this is something that is very important that the governors should know, because this should be a common practice. Not all patients can discontinue treatment, but those who can safely, we can save many expenses that can be used in other for the monitoring and also for other clinical situations. In Latin America and also in Brazil, we had our guidelines for discontinuation. So the major requisites for stopping treatment, this was only for adult patients. We did not include pediatric patients in this guideline, but it's the usual CML in chronic phase with optimal response to TKI, patients in more than 5 years of TKI therapy, since most of our patients are using imatinib in frontline, and deep molecular response. Here we established MR 4.5 for at least 2 years. Maybe we can do this discussion to stop with MR 4, MR 4.5, but in this first guideline, we wanted to be more conservative for the discontinuation. And then the usual monitoring in the first semester, once a month, second semester, every 6 to 8 weeks, and after 12 months, every 3 months. Also in the Latin America recommendations, we have a very similar frequency of monitoring after treatment discontinuation, and the definition of molecular relapse of PCR more than 0.1% loss of major molecular response. But in this guideline, we also included the how to do the monitoring after TKI reinitiation, and also how to manage the withdrawal syndrome, how to inform the patient before discontinuation, the psychological aspects, and also the additional laboratory follow-up after discontinuation, besides the BCR-ABL monitoring, other metabolic tests that we should do when patient stops imatinib or nilotinib. So all this can be assessed. It was published 2 years ago. And this picture, it was taken in 2018. As Arlene mentioned, this group climbed Kilimanjaro for a very great purpose. It was to raise money for research. And we are going to do it again this year. And this familiar face here are Nicola, Ehab, and me. Okay, so now maybe we can go to the first case. The first case, and I'm going to talk the case, and then Ehab will do the discussion. So this patient was a male patient, 60-year-old, was diagnosed in CML in chronic phase with a low SOPA risk. Diagnosis was in 2019. The only comorbidity was hypertension, and the patient was treated initially with imatinib with good compliance and achieved cytogenetic response and major molecular response at 6 months, very early. And after 4 years, he had achieved MR4.5. Then years later, almost in 2017, patients started to have progressive thrombocytopenia, reaching 5,000 in 2019. He was asymptomatic, he had no bleeding, but we started to investigate to exclude other secondary causes of plaquetopenia, thrombocytopenia, such as hepatic disease, viral diseases, the steroid dysfunction, autoimmune disease, but we didn't find anything. We did a bone marrow aspirate and biopsy. It was slightly hypocellular, but has no dysplasia. Normal, the karyotype was normal, and the patient maintained the CMR MR4.5 in the BCR-ABL monitoring. And this patient, he met the criteria for discontinuation, so we included this patient in the clinical trial that we are conducting. This trial, there is a phase of dose de-escalation in the first 6 months. So the dose was reduced to 200 milligrams for 6 months before discontinuation. And after he stopped the imatinib, we did the molecular monitoring. And then I'm going to show in the next picture what happened with the platelet numbers. So the patient was using 400 milligrams imatinib. Here was the diagnosis, and then here was the dose reduction when he entered into the protocol. And when the dose was reduced, the imatinib, the platelets started to increase. And after discontinuation, the platelets reached a normal level. And this patient is still in the trial. He is without treatment in TFR, but he had a resolution of this thrombocytopenia after imatinib discontinuation. And so I'm going to open to discussion if Ehab wants to ask something or comment.
Yeah, I think, hello, everyone. I think it's interesting. It's really interesting that you followed the dose reduction followed by stopping. I mean, I know that was a study. So that's one way of doing it. Does anyone in your practice for patients who want to discontinue, have you seen that they prefer to do a dose reduction first before stopping? Have you seen that patients want to do that as opposed to stopping right away?
Yes, as I mentioned, there are some barriers to stop treatment outside clinical trials, but in general, when people usually stop treatment outside clinical trials, most of people stop when there was a toxicity. So in this case, sometimes the patient was already dose reduced because of the toxicity. We have some patients in the clinical practice that we have stopped treating, for example, for nilotinib when patient had a arterial problem or infarction or ischemic disease. And usually those patients were already with dose reduced because we have previously done that, but not as a routine, I should say.
I can tell you that I'd say maybe 20-30% of my patients who are eligible to stop, so they fit all the criteria for stopping, they feel nervous of just like suddenly going off drug, and they just feel better in this way of like, let me reduce it for a year. Like I just saw a lady yesterday, I reduced her to 300 for a year, and then she said, can I go down to 200 for 1 year? So Jerry, have you seen that? I mean,
oh yeah, I mean, I have lots of patients who basically say, if you spent 5 years, beating me up and down that I had to get religiously tested for, testing every 3 months, and now you told me I can just stop drug. Like, what is it with you guys?
Make up your mind. So and we do have, we do have good data with the Destiny trial, right? Because that's what the Destiny trial did, where they reduced the dose first for a year.
Yeah.
And then patients went off drugs. So
I think you can certainly get away with it. I thought this wild about this case is that how late the platelet count tanked. It may be one of the problems of living at a tertiary cancer center, but whenever I see a patient who's referred in for a declining platelet count like this far out, it's a disaster, right? They've got a deletion 5 or a deletion 7 or something, and they're going into MDS and AML. So I just haven't seen many where out of the blue their platelets go down, but everything else is fine and nothing, no myelodysplasia or nothing else. So
yeah, this case was very atypical because the platelet started to decrease very late in the imatinib treatment.
Yeah, strange.
I think it's the only case I have with this behavior.
Yeah.
Very, very weird. You're right. Like you wouldn't see it this late except with some other disease. But the good news is it recovered as soon as you stop the imatinib. So it's definitely
it's fine.
But it was related.
Definitely related. You didn't find anything else.
Ehab, you talk about reducing the dose, and in this trial, what we are seeing that patients, they started doing very well with the dose reduced. Sometimes when they relapse, they say, "Can I go back to the dose reduced?" I was feeling so good because they feel the difference when they cut the dose by the half.
Yes, and that's. Sorry, go ahead.
So I might step in and say, if anyone else has any questions in relation to this case, please put them on the chat or raise your hand. Bruna, I can see you've raised your hand. Sorry, Ehab, we'll come back to you in a second. I didn't mean to cut you off. Bruna.
Hello. Good evening. Do you think that reducing the dose could diminish the risk of withdrawal syndrome, for example?
So, Katia, shall I take this?
Yes, I can talk about the experience I have first, and then you can complement. I noticed, Bruna, in the first trial that we did that we stopped the treatment, we had more withdrawal syndrome than this one, but I haven't did the statistics yet.
Oh, okay.
But my opinion is that yes, it's better. It diminishes the risk of withdrawal. I don't know if you have experiences different.
Yeah, I agree. Doing that does, clinically, from my experience, does reduce the withdrawal syndrome. And also, it's not a head-to-head comparison, but the Destiny trial, which did that, reported less withdrawal syndrome. So it's not a head-to-head trial. Maybe they didn't collect it in a different way. You can put in so many ifs and buts there. But that's the data that we have, and from my personal experience, it does reduce the withdrawal syndrome.
Yeah, the reduced. Sorry, go ahead.
Oh, sorry,
go.
you can continue.
Go.
No, go. And it's another question about the risk of selecting a clone, for example, if you reduce the dose instead of.
That's what I was going to get to. When this is another example of countless examples of when I'm wrong. I thought reducing dose would be bad because, the Ames test, right? Bruce Ames from Berkeley, when he developed ways to make cell lines resistant would basically keep lowering doses, right? And eventually that would create a Darwinian selection for a resistant clone. So I always thought, well, this is nutty. It's going to be bad, right? But so far it hasn't been. So, go figure.
Yeah.
Maybe one
Thank
last
you.
comment, and then we'll move on to Katia's second case. We can come back to this later in the general discussion, but perhaps one last comment,
Thank you.
Ehab?
Yeah, I was going to comment on the reduced dose. We have data for dasatinib 50. We have data for nilotinib 300, and then reducing the dose when patients respond. We have data for ponatinib at a higher dose, and then we reduce the dose. And really, in all of those, we haven't seen any evidence of resistance with using the lower dose. I think the data now is pretty strong that it's okay if your patient is responding appropriately.
Yeah. And I think that just goes to underline that for every TKI so far, when all of our studies have picked the right dose, it turns out not to be the right dose, right? So whatever we're doing has reproducibly not worked in defining the right dose through clinical trials.
Okay, Katia, would you like to move us on? We can come back later.
Okay,
Just running out of time on one
the
case.
second. Yes. Okay, let's go to the second one. This was a female patient that was diagnosed with CML in April 2019. She had a hypertension as comorbidity, and she has a clinical picture of CML in chronic phase. She had a typical BCR-ABL transcript, and she was a so-called intermediate risk group. This is the bone marrow diagnosis, a very hypercellular bone marrow with atypic megakaryocytes, typical of CML. And then she started treatment with bosutinib in first line. The starting dose was high, 500, because she was participating of the BELLA clinical trial. So for those who are not familiar, it's a trial that randomized imatinib and bosutinib in first line. And so she did all the protocol evaluation, had no cardiac problems. She had only interruptions due to diarrhea. That's very common in the beginning of bosutinib treatment. She was managed with medication and dose reduction, and she achieved a complete cytogenetic response and major molecular response at 6 months. And then after 6 years of treatment, she began complaining of progressive dyspnea. And when we did an echocardiogram, we had a pulmonary artery hypertension. Unfortunately, we were not able to do the study, the catheter study, to prove that it was a real pulmonary hypertension. But when we interrupted treatment for 4 months, the pulmonary hypertension reduced a little. And then after reintroduction, there was a raise in the arterial pressure. So we decided to definitely stop treatment. And this was one aspect of the case. But then since 2014, she presented increasing lymphocytes in the peripheral blood. So this is the, in red, it's the lymphocytes curves. So in 2014, 2015 started to increase. And then when we stopped the bosutinib here, there was a higher number of lymphocytes. Now it's over around 40. And in green, we see the BCR-ABL counts, the major molecular responses here. So, so far, she's still in TFR, no evidence of CML. And the flow cytometry of the lymphocytes showed that it was a B-cell lymphoma, probably a marginal zone lymphoma. And we are doing only the watch and wait approach because it has no splenomegaly, no hepatomegaly, no lymph nodes enlarged, only increasing the lymphocytes in peripheral blood and asymptomatic. So we have now how many years of follow-up? From the lymphoma, about more than 5 years, and she's in the 6th year of TFR, is undetectable disease.
So I don't know, Katia, what you're doing to your patients, giving them non-Hodgkin lymphoma. That doesn't happen. So
my only case,
I've seen, I mean, I don't think there's any data that, the first thing, I don't think there's any clear data that shows that the TKIs or CML predisposed to other diseases. I think it just happens, especially if lymphoid. I mean, I've seen CML and MPN. I've seen MPN, and then they develop CML. I don't think we have any correlation, and I think you agree with that, Katia. Like this was not a cause and effect.
Yes, we
I think
go back to the bone marrow from diagnosis to see if there was lymphoma there, but there wasn't. We did immunohistochemistry in the biopsy of diagnosis. It came during the follow-up.
Yeah, I think what's interesting is the bosutinib. I mean, again, this was on clinical trial of the choice of first generation versus second generation TKI, and I think that's a question that will always will be very hard to answer long term. So, in regards to TFR specifically, right? Like we make assumptions that if you start on a second generation TKI, you're more likely to get to TFR. That's not like, we don't have any real data for that. Like if you look at all the randomized studies, they never ended up with TFR. We make assumptions based on the response rates, but we don't actually have data on true TFR. And what I thought was really interesting in your first presentation, I didn't know this data, that I think the Colombian paper that you showed, they had 500 patients with CML, right? But only 30 of them, that's 10%, were even eligible to attempt TFR. Don't you think it's a really low rate? I mean, you think it should be higher than that.
No, I don't think so. I think they are right, because if you pick up today, in my center, for example, that I have almost 300 patients in treatment, 12% of my patients are in TFR. I have some other patients that could be eligible. Yes, 12% are in TFR of my patients.
No, but eligibility, like the Colombian had eligibility, was only 30 patients out of 500 were even eligible, not actually achieved TFR, were even eligible. So a much smaller percentage.
Yes, but sometimes patient is eligible, but patient doesn't want to stop treatment. There is this situation too.
Absolutely. So what I'm trying to say is, in the real world, like in actual like everyday practice, we don't really know, outside of clinical trials, how many patients are able to achieve TFR.
Right. So, you know, we're kind of dealing with this stuff with work I'm doing with the Max Foundation. So if you look there, they have thousands of patients who have been on imatinib for more than 10 years. And none of these people, or very few of these people, get monitored, right? So the first thing, you can probably bet that if you've been on drug for 10 years and are still alive, you've got a pretty good response. You know, so then the issue is, well, if you really wanted to optimize TFR, it's not reasonable to suddenly, you know, because you don't have any PCR results on these people. So you can't like parachute into these countries, do PCRs, and you don't know what they were before, and to do then 2 years of monitoring to prove they're in a deep molecular response, you know, that's not fiscally possible. And do you need to, right? And so we're working now with some mathematicians looking at the Kaiser database in the United States, big hospital chain. But the idea is, if you know how long people are on drug and you know how deep they are in a single time point, can you predict what's going to happen in the future? And so it may well be that if you have someone who's been on drug 10 years and they have an MR of 4.3, you know, and you look out in the future, on drug, they may stay at that level forever, and they're probably pretty safe to take off, right? So, you know, when we did all the monitoring stuff years ago, this is ancient history and is kind of a different subject. We based monitoring recommendations based on what the recommendations were used in the transplant setting for CML, which was PCR every 3 to 6 months. And we decided to stay at 3 months because it was easy for doctors to remember, right? There was no biological rationale for it at all, right? It was basically, this will be easy for people to remember, but it's probably stupid, right? It probably means that we monitor some people not enough and some people way too much when you think about it. We monitor people who go from diagnosis to like, zero disease instantly. And we monitor those people as much as someone who takes forever to get to an MR of 3 logs, right? Those are probably completely different diseases and need a completely different way to think about monitoring. But right now we basically just say, okay, everyone every 3 months, right? So that's, it's easy to remember, but it's not biologically, very clever, to say the least.
So I'd like to ask you, both of you, one thing that is that's always we think about when talking about TFR. Patients start treatment in the same conditions, stop treatment in the same conditions, but half relapse, half don't. Would like to do a comment about this, about the immunological aspects of the TFR.
Well, we
Jerry,
know,
you'd probably say that better.
So we know from both studies with flow cytometry, gene expression stuff, et cetera, that the immune system is immensely important in achieving a TFR, right? So we know that. Afterwards, after TFR, there's some data that suggests it, some from looking at cell populations in people who are successful and not. Some in the fact that some patients will start rising their BCR-ABL, and you would think it would go on forever, but it gets stuck at around MR3, like there's some effect that's going on and it doesn't go past that. That suggests that maybe some immune system is being activated. When we looked at patients in TFR prior to discontinuation, from the 2 biggest Novartis studies, so what, NS Freedom and whatever the other one was. So that's like 400 patients where we could do, and we did RNA-seq on all those patients before they discontinued. There's 0 differences between those 2 groups. So now that I couldn't get Novartis to do the logical step, which is what happens after you take the TFR away. And so we're doing that now where we have sequential samples on people from Ehab's last study, where we basically say, okay, maybe it's no surprise that when they're in a deep molecular response, there's no molecular differences. They're still on drug and they have a deep response. But if you take the drug away and then see, is there an activation of immune pathways, that we'll find out. I would guess probably. So you may not be able to pick them out before you start, but you may be able to pick them out pretty soon, right? You may be able to say after 3 months, by their rise in the BCR, by digital PCR and by activation of the immune system, where you might be able to say, okay, these people are going to fail, don't bother pushing them out to actual relapse.
Yes, now just mentioning about the immunologic features of those patients that interrupt. We are going to publish, or it was just accepted in, so it's not in PubMed yet, but it's the immunological analysis of our AST Argentine stop trial, where what was analyzed were the cytokines, interleukin-6 and MCP, and when one of them was low, both of them were low, it showed that they were predictors 8 times more, 8 times fold higher for risk relapse or to lose the molecular response. So we make like a predictor using variables, clinical variables and immunologic variables. And in the immunological variables, these cytokines were the ones who were most predictive. Obviously, these were in 46 patients. We need more patients, we need more data, but I think that the thing goes around the immunological, the immunological aspect now to maintain the TFR.
Were these with the Adelaide samples?
Sorry?
What trial was it from? That's great.
It was the Argentine trial.
Okay, great. Yeah. Great. Yeah, great.
But it was presented last year in the John Goldman conference as a poster, and it was done by flow cytometry.
Yep, perfect. Great. Great.
There's a question in the chat that I might pick up. In the case of a patient who's had a complete molecular response for 4 years and qualifies for TFR, but a transcript level of 2.6 appears in the checkup control, which is not reiterated in the subsequent study, how long do they wait before starting TFR?
Well, I'm like a transcript level of 2.6, you mean like, could you, Anna, could you just clarify that? What do you mean by transcript level of 2.6 and the checkup control? Could you clarify that a little more, please?
Yeah, it's a checkup control just before they stopped in discontinuation in another lab. What does that mean? Sorry.
Ana Inés.
It's 2.6%. It's
Sí, estoy
2.6%.
acá. ¿No me escuchan?
Sí, te preguntan, no sé si querés que te traduzca
Sí.
o... Sí,
No,
ellos te
o
preguntan.
sea, fue sorpresivo y en realidad la paciente presentó 2.6 en el transcripto de BCR-ABL en escala internacional con un logaritmo de 2. No nos queda claro si no hubo un tema con la identificación de la muestra, pero el tema es que, bueno, es el resultado que tenemos. Después se repitió el estudio y volvió a ser una respuesta bien profunda, pero no sabemos cómo hacer ahora, si esperar 2 años para discontinuar o si puede discontinuar antes.
She says that the patient had just one test of BCR-ABL. The percentage of the transcript levels was 2.6, but it was a 2.6 after a molecular remission, a lot of years, 4 years, appeared this 2.6% of BCR-ABL, and they were a little bit, they didn't know what to do because they don't know if the patient that is now in deep molecular remission again must discontinue or if this is a risk. The laboratory is the same. Estaba en escala internacional.
Sí.
It was in international scale always and the same lab. What's the explanation you can give perhaps to this rise in the, perhaps it's like a molecular defect or we always try to repeat, no? That's the thing, no? What is your opinion of this? This happens routinely.
So it was 0, 0, zeros and then 2.6 and then zeros again?
Yes.
And what's that, like when you repeated it, how soon, like you repeated it like right away and it came back 0 again?
Yes.
¿Lo repitieron enseguida?
Sí, lo repetimos más o menos a las 2 semanas.
Yes, two weeks from the 2.6, they made another PCR. And it was in deep molecular response.
Yeah, I think Jerry can, I mean, I would say that's an error. And I mean, if it's been straight zeros, 1, 2.6, and then zeros again, I would say the 2.6, someone messed up the sample.
She wants to know if she has to wait 2 years more.
I wouldn't. I mean, if it's straight zeros, 1, 2.6, zeros again, I would say the 2.6 is an error. So we specifically in our studies, we allow for that because that can happen. So in the eligibility criteria for stopping for the studies, we allow for, we say 4 tests, 3 months apart in 2 years that were less than 0.01 to allow for errors like this. Jerry, do you want to comment?
Yeah, no, I would think that's got to be an error, and I would think that if you really want to be safe, you can wait another couple months. But if it's hard to explain how someone on therapy would have what is essentially 1,000-fold or more rise, and then suddenly go back down on their own. I've never seen that happen in my billions of PCRs.
In 2 weeks.
In 2 weeks,
right?
Yes,
in 2 weeks. So, yeah.
Sí, dicen que es raro. Generally, we have like a rise, MMR 0.1 perhaps, but not such a rise. So this is like strange.
Yeah.
Bueno, dicen que creen que fue un error del método, Ana. Y que lo suspendería, dice el doctor.
Yeah. 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 You can't explain that with doubling times.
Do we have time for one more question, Arlene?
Notice you had a third. Okay, we're actually out of time. Can we do it really quickly?
Yes, it's a really quickly important question. What about the sudden blast crisis that is very unusual, but it was described in some patients that have all the criteria for discontinuation? I'd like to listen to hear Jerry's opinions about this sudden blast crisis in patients in TFR.
I think it's hard to explain. The people that we've seen that are like that, when we've gone back, looks like they really didn't fit all the criteria for TFR. They weren't on long enough, or there was some question about their molecular response. Although I think it's probably, one of the risks I think we have whenever we talk about BCR-ABL and discontinuation and the like is, CML is a very strange disease. The Japanese still do follow-up studies on Hiroshima and Nagasaki survivors. And the last time they did the evaluation just a few years ago, and they have control groups for these populations, there was still an excess of CML in blast survivors 70 years after the blast. And we know that when those people got CML, they got it on the blast date, right? So the latency period can be very long. So I think there are patients out there that do have clones that are blast crisis-like. We've seen that before in gene expression studies where people who are said to be in CML chronic phase, these are resistant patients, who look by all the world like they're in chronic phase to the pathologist are blast crisis, clearly, by gene expression. So it wouldn't surprise me in rare patients, there's a clone in there that's suppressed, and once the drug is taken away, there you go. It's curious that it looks like in a lot of these, it's more lymphoid than myeloid, which is kind of wild. And certainly that's our experience in our clinic, is the patients we've seen come not only in situations in bad TFR management, but in just a natural progression. We see a lot more lymphoid blast crisis than we ever did before the pre-TKI day. And I don't know what that's all about, but that seems to be something that a lot of places have been seeing.
Ehab, do you have any last comments here?
So the other thing too, Katia, that I explained to patients is that even if you look at ENEST and D, all the studies, 4 or 5 years out, the incidence of blast crisis is 0.4%, right? So it's not 0%. So even patients on drug can still have a very low incidence of progression to lymphoid. And I agree with Jerry. Like, I just had a patient 2 months ago, 10 years out, on TKI, not off TKI, on TKI, lymphoid blast crisis. And there were zero signs that this would happen. So what we know currently.
It even happens after transplantation. Even after transplantation, if you look at people who got myeloablative transplants and are survived 10 years free of disease, their relapse rate is about 0.4% per year after 10 years. So even with ablative transplants and a whole new immune system, there are clones that survive.
So that's why I don't think it's necessarily like it's a TFR thing. I think it's a disease thing, because even on drug it can develop. So
yeah. And on that cheery note, we'll go to the next.
That was definitely worth extending the time a little bit for there. Thank you very much. But unfortunately, we're out of time for the TFR topic, I'm afraid. So thank you very much to Dr. Katia Pagnano and Professor Ehab Atallah for your insight and your wisdom, and to all of the audience members for your contribution. Our next speakers indeed. If you submitted any questions on the chat that we didn't get to, I will get a response from you afterwards and get back to you. Likewise, if you'd like to submit a comment or a question after the fact, I will get a response from you and get back to you.